Hello, lab experts. Welcome once again to the Rock Diagnostics podcast. In today's episode, we sit down with a professor and research director of psychiatry, Michel Boivin, or Boivin, if you want to say it in French. And we're going to be talking mostly about his work, but specifically about the effects of malaria in pregnancy on the neurocognitive development of children. How are you doing today, Michael?
Very good. Thank you
It's
for
nice
the
to meet.
opportunity to share our work.
Thanks a lot for taking the time to come over. So tell us a bit about yourself.
Well, my background actually is training in experimental psychology and psychobiology laboratory and animal research. But then after a trip to the Democratic Republic of Congo with my wife who grew up there and her family, and for a month in 1989, based on some preliminary work I was able to do on that trip, we returned for a year, 1990-91, as a Fulbright award for a full year. And that year really changed my life, sent me in a new direction, mostly in child development in sub-Saharan Africa, in response to risk factors and the factors that strengthen them against that risk. And I've been working in neurodevelopmental, neurocognitive areas ever since. So for the past, 33 years now.
So let's say a bit more directly to the paper I was referring to a bit earlier. Neurocognitive development is, well, of course, there are some complicated malaria cases that tend to affect the brain, but where did the idea to try and see whether there were effects on children while they were still the mother's womb, where did that idea come from?
Well, there's been an awakening, so to speak, within developmental neuroscience of the importance of the first 1,000 days, and that includes gestational time in the mother's womb up through then the first, say, almost 2 years of life. The first 1,000 days of development are strategic in that they set the direction of the child's neurodevelopmental, neurocognitive, not only in infancy and through early to middle childhood, but now we're finding out into adolescence, young adulthood, and throughout the lifespan. And if you want to redress risk factors causing neurodevelopmental disability, the earlier you can intervene, even but certainly within the first 1,000 days, the earlier you can intervene, the more dramatic an impact that in giving these children a chance to really fulfill their God-given potential in life, neurodevelopmentally, neurocognitively, their quality of life, and all that they can give back in successive generations.
One thing I was really surprised by when I was reading the paper is that I think at one point there was an information share that about 200,000 fetal deaths every year are caused by malaria in pregnancy. I was really surprised by that. It's not something that we hear about very often.
Yeah, and that's been a real debate. Now, my early work in 1997, I spent several months in Senegal. It was my first retrospective study on the neuropsychological effects of cerebral malaria in surviving children. And then later on in 2003-04, I was able to spend a full year in Uganda. That was on our second Fulbright Award, actually introducing neuropsychological studies in collaboration with an infectious disease physician, malariologist, Dr. Chandy John, and we worked together with our Ugandan colleagues and team that year in a research program that we began looking at the neuropsychological effects of severe or complicated malaria, which can take the form of cerebral malaria with coma, seizures, brain inflammation, brainstem herniation. And at that time, in 20 to 25% of children hospitalized or not would result in death. And then later on began looking as well at uncomplicated malaria in children and mothers during pregnancy for their children, and ways in which that seemingly asymptomatic, non-complicated malaria could cause anemia, could cause some serious risk over time in children, and that could contribute to the morbidity of malaria and its human cost as well.
The children So from what I saw in the paper, what you essentially did, you took the mothers and then you tested them during the pregnancy and also the children at 1 year of age and then at 6 years of age. What were some of the tests that were done to assess their cognitive capabilities or to try and determine if there was any effect of malaria on those children?
Well, beginning, with our school age children who had survived cerebral malaria, who we enrolled in our prospective study. It was the first prospective study of children from the time they were admitted in hospital, in this case at the National Referral Hospital in Uganda, Malago Hospital, following them forward in time for 2 years with Western-based tests that I had worked hard to select, that I had originally piloted in the Democratic Republic of Congo during my 1990-91 Fulbright year, adapting those within that language and cultural context, and finding that as long as you didn't use these Western-based tests in any kind of unfair cross-cultural comparison, as long as you had comparison groups within that cultural context, whether in the Congo or in Benin and Uganda, the children exposed, in this case, to severe malaria versus children who had uncomplicated malaria, were not hospitalized for it, compared to children without a history of serious malaria or blood tests that would evidence thereof at the time of our assessments. As long as you had comparison groups within that cultural context, you could use these school-age Western-based tests designed to be more culture neutral or culture fair, and obtain really good measures of working memory, of learning ability, of planning, reasoning, visual, spatial processing, and problem solving. And that with those kinds of far more in-depth measures of neurocognitive performance, you could then gauge how well children recovered from cerebral malaria, what were their persisting neurocognitive disabilities, even 6 months, a year, 2 years after. And then later on, we took a number of those children and enrolled them in a cognitive rehabilitation with computer cognitive games training to see if those children who had persisting memory or attention or other kinds of learning impairments, and about 1 out of 4 of our surviving children had persisting neurocognitive problems even 2 years after recovering from cerebral malaria, that if we could go in and do about a 2-month computer cognitive training program specifically targeted for their memory, for their learning, for their visual spatial analyses, problem solving, even some of the games that we've developed more recently for reasoning, planning types of skills, that if we could go in and do 2 months of training, which these kids often very much enjoyed, their first exposure to these kinds of games, that we could actually document improvement in those neurocognitive skills independent of the training tasks themselves from before to after, even though a year later some of those improvements had diminished. So it would be important to keep stimulating, keep enriching the cognitive environment of these children, probably throughout their middle childhood.
All right, so that means it's actually possible to help them get to a level that's more, let's see, at the level where they can be a lot more effective despite having the past.
And there are and I guess that's the advantage I brought to the study of the neurocognitive effects over time and the potential rehabilitation possibilities for children surviving complicated or severe malaria in this case, is because I'm coming at it from my background in experimental and behavioral psychobiology, but working in a medical context with physician scientists who are very attuned to, well, what kinds of other kinds of treatments can we add to the traditional standards of care for children in coma, suffering from seizures in the aftermath of cerebral malaria, not just keeping them alive, but now going forward in time, what can we do to enhance their cognitive rehabilitation? And so the combination of combination therapies during the acute phase of the disease, when children are admitted, they're in coma, they're in a medical crisis period, and combining various types of additional treatments and, beyond um, uh, artesunates and beyond the kinds of traditional standards of care to remedy, incessant seizures and so on. Not only the combining those with other kinds of medical treatments, but then and the aftermath over time, what else can we do to help rehabilitate and enrich their lives? And that's where the cognitive computer games can come in, and with very young children, again in those first 1,000 days. We've also worked with training caregivers, mothers, caregivers, that in ways that they can enrich the home environment of their infants, toddlers, their very young children, so that they can, going forward, these children we can reset their developmental trajectory from one of risk and diminishment and suppression of their cognitive potential to one of recovery and enhancement, and to encourage them to achieve their full potential throughout early childhood, in middle childhood, and beyond. So really the combination of medical treatments and behavioral treatments is really where the future of child development in low and middle income countries and in sub-Saharan Africa needs to move. Whether you're dealing with children who have recovered from a serious brain infection like complicated malaria in their early childhood years or beyond, or else children with a chronic infection, say pediatric HIV through perinatal infection, or exposure within the womb through the first 1,000 days to maternal HIV and the effects of combined antiretroviral therapies, or malnutrition, or toxic exposures from heightened cyanide within cassava, like the kind of work we're doing now in the Congo. Whatever the risk factor is, whatever the infectious disease is, the combination of both early treatment and behavioral interventions that are appropriate to that developmental season for that child, maybe caregiving training in early childhood, moving into cognitive games as those children reach school age years and beyond, to other kinds of educational and social enrichments, that those kinds of enrichments to give a child a leg up across the lifespan is really the future now, I think, in that child development world. Yeah.
Yeah. And training the mothers to try and develop a more enriching environment at home, what does that usually entail? Because I'm assuming that in some of these areas, it's not necessarily people who can go digital. How can they go about helping?
Yeah, that's a really good question. Because whereas the kind of digital environment through smartphones, tablets, and through mobile phone platforms that are access to the internet and beyond to the cloud, that becomes more and more of an option now throughout the developing world, especially as children grow older into their school age years, and provides a way of enriching their cognitive development, even if they're locked down at home in the midst of a pandemic. Boys and girls equally, and no matter whether the family can afford school fees, for example, which often would prioritize certain children within the family. No matter what, a digital environment can be harnessed not just for entertainment and for social networking, but the digital environment that children have more and more access to throughout the global world these days can be harnessed for their neurocognitive and social and even moral and faith-based enrichment and enhancement, if used properly, if used and engineered in a socially positive way. But really young children, before they reach that level in their development, are responding primarily to the caregiver, to the mother, hopefully in most cases, and that her nurturing care, her emotional responsiveness, her willingness and ability to interact with the child moment to moment, day to day, throughout the course of a normal day's activity, whether washing or feeding or cleaning or shared work or even shared play. And so the caregiver training techniques that we utilized were not so very different from what UNICEF and the World Health Organization and other kinds of global health-based humanitarian organizations are now enriching and encouraging, financially and through materials and through manualized programs that they make available, particularly to those in communities that are at risk. We train the moms usually every other week, alternating at times between the mom's home, going to the mom in the home, and the office, if there was an office nearby where we had better access to other kinds of video and teaching types of materials and curricula. And so, say we would go into the home with trained caregivers, usually women who were perhaps successful mothers themselves and utilizing these techniques, who had then been hired and trained further and enlisted as peer trainers who could work with other mothers at risk within their communities, their neighborhoods, their village, their town, and then go, say, every other week into the home and spend maybe an hour with the mother as she's there with her 2-3-year-old child who's at risk, maybe in the aftermath of severe malaria, maybe malnutrition, maybe pediatric HIV, maybe exposure to HIV in the womb and beyond. Whatever the risk factor was, the field trainer, a successful mother herself, training other mothers now peer to peer on specific ways to enrich the environment, and somehow using peer trainers from the community, mother to mother within that setting, even in small groups, so as to, alternating individual training with small group training within the neighborhood or community, whatever to optimize the cost benefit ratio in terms of maintaining this kind of intervention, that over time we could actually document significant improvements using other kinds of validated tests in the neural development of the children, significant improvements in the emotional well-being of the mothers themselves receiving the training. They were less depressed, less stressed, less anxious. And furthermore, a finding we did not expect was that the children themselves, let's say in the context of pediatric HIV, mothers receiving this caregiver training, their children surviving with HIV, we had significantly less mortality in those children because by sensitizing the mothers and enriching their caregiving, when the child became sick, let's say from opportunistic infections and illnesses within the village, that trained mother, even at great personal cost and sacrifice, would make a greater effort sooner to get that child to clinic within the town or village, which is often took quite a bit of effort. And it turned out that reaching clinic with these opportunistically infected and ill children a day or two sooner, because of the mothers having been sensitized to all the needs of their child, not just developmental, but medical, social, nutritional, that day or two difference in reaching the hospital sooner with the mothers who were being trained with this caregiver training made all the difference oftentimes. And we had significantly less mortality in our initial studies when we were using these techniques in Uganda with mothers infected with HIV whose children were perinatally infected as well.
Yeah. So all this, it sounds like very involved long-term projects. How is planning usually for these? Is it more structured? Is it at the beginning you sit down and you try and figure everything out and then it's rigid? Or is it more organic, and maybe sometimes in the field you find out, you get new data that allows you maybe to implement new solutions? What's the process usually like when you're on a...
No, it's a good question. Most of our projects are supported through the National Institute of Health, so they're really scientifically based projects. But there's more and more of an emphasis now on not just science for the sake of science, but bench to bedside, meaning science that can have real world application and impact and benefit to public health needs more regionally or even globally. And so our initial proposals for which we try to receive funding to test concepts like, can early caregiver training enhance the development of children perinatally infected with HIV or even exposed to HIV, but perhaps uninfected within the first 1,000 days beginning in the womb? Say, or can we enhance child development of toddlers who have survived severe malaria anemia or cerebral malaria, let's say? So we come to the NIH, to the appropriate institute. For us, it's often the National Institute of Child Health and Development. And we come with a proposal. And usually these are scored, and it's a very, very competitive evaluation process. Typically, only about 7 or 8% of grants that are submitted to the National Institute of Child Health and Development of the NIH are eventually funded. And so you may have to try several times, each time trying to improve the grant. So the science at the onset has to be really tight and very rigorous. But then let's say that you're blessed, you're fortunate enough to be funded, and now you get a chance to actually go to Uganda, to the Congo, to Benin, to wherever you're going to go in the sub-Sahara, and to implement this intervention project for the well-being of mothers and their very young children. You go in with a plan and a protocol, with a curriculum. In this case, we had a very well-developed caregiver training curriculum that was a year-long, involved every other week, and had been piloted before in Ethiopia and in other parts of the developing world. So we just didn't just develop our own. We partnered with a developmental psychologist, in this case, Nina Klein, who's now passed away, but who had dedicated her professional life to child development and to this particular caregiver training intervention program called MISC, or mediational intervention for sensitizing caregivers. And it was a very rich and in-depth conceptual program that she had, she and her colleagues at Bar Ilan in Israel had developed and dedicated their professional lives to validating within low and middle income countries. And we were the first to partner with her to use that initially with pediatric HIV survivors in Uganda, and then from there other countries within Africa, including South Africa and beyond. So in this case, we get to the field with this curriculum. We partner with community leaders now, and usually those are the local within Uganda, your local, say your political tribal community leaders who are stakeholders within whatever kinds of interventions that we bring to that community. Partner with them. We go through the program. They help us adjust it to be culturally appropriate within that ethnic group, within that community, within that political and ecological and ethnic climate. Yeah. And so we adapt it through usually a few month period of refining it to really fit that community, and translating the various lessons and instructions within the local languages as well. That needs to be done carefully, both for your interventions and for your assessments, making sure the technology works. We're videotaping mothers as they interact with their children at different points in time, making sure that process is workable. We get the appropriate consents. We do it in an appropriate way that doesn't threaten or divulge or put at risk the moms and their children in terms of their identity in any way. So we adapt the intervention within that community while staying within the principal study aims. Then we implement the project. We're flexible. I mean, you realize that you've got to be flexible, but at the same time, you've got to adhere to your principal study aims and goals. You just can't go off in whatever direction that you want once you're funded to do these kinds of studies. Then at the end, if we're finding it's effective, then the next step ideally is to share your results with the community, then partner with the community leaders as to how can we make this sustainable now, is this something that the community itself can now, in a sense, sort of be, we can hand off the implementation of this um, to the community leaders, and they can continue it at some level. And that often works better than necessarily than going to a government ministry, let's say, and trying to convince political leaders to invest in this type of intervention, because that political leaders change as governments change, as ministries rise and fall in terms of their political clout within a given administration, depending on where you're at in Africa or even in America, as we well know. And so, if you could get the community to buy in and commit to sustaining it, at least at some level that's workable for them, and then as other leaders, regional leaders and ministries begin to take notice of the changes that have come about, the benefits, then programmatically they can seek other donors who specialize more programmatically, like USAID, for example, like Gates Foundation, like UNICEF, and like WHO and other major donors, getting them now to invest at a more regional, at a more national level programmatically. But our experience has been starting small and building up from there, with the initial investment coming from the National Institutes of Health. That's kind of the path we've followed and what we've tried to develop. Yeah.
Yeah. So you said it's extremely important to get buy-in from the community. Can you give us, let's say in your experience, an example? Where do you think the strongest response you got from a community was as far as buying, and what do you think you were able to do that really reeled people in and made them really interested in the project?
Well, I'm going to switch gears now, because one of the projects I'm most excited about right now that we're currently involved in is Konzo disease within the Democratic Republic of Congo. And I should explain a little bit about that. It's very different than, say, malaria or HIV, in that Konzo, it's from a local language word within the Congo Basin, Yaka language word, meaning bound legs or tied legs. And the most obvious symptom for children and or adults affected by this disease is that their gait, their walking can be severely affected or restricted, even to the point of paralysis of their lower limbs. So early on, this was first documented by a Belgian physician, Trolley, in 1938, first described this disease within the medical literature that he had observed as a missionary physician within the Congo. And later on, in the early 1980s, mid 1980s, a Scandinavian group at Ubigen discovered that it was that what was actually causing this disease was not a virus, it was not genetic, it was not some kind of derivative of polio, whatever. It was caused by toxic cyanide within the basic food staple, which at that time was and continues to be cassava or manioc. Now, the bitter cassava that is resistant to disease, that tends to thrive in these more acidic and dry soils within the Congo Basin, given its deforestation and its ecological degradation in many areas. The kind of cassava was brought from the Amazon by Portuguese traders in the 1500s, it turns out. But it turned out that this bitter cassava, which is a more robust, resilient cassava within these hard growing conditions, thrives. It can get multiple harvests. So the cassava itself, it's like a root or a tuber beneath the soil. And the bitter cassava, one of the things that makes it resistant is that it tends to be higher in lanamarin, which has a high cyanide content. Now, typically, if you're having other sources of protein, sulfur-based amino acid proteins in beans or in meat or fish, whatever, your liver can detoxify the cyanide, and it doesn't pose a threat. And traditionally, within the culture, when I worked in the Congo in 1990-91 for a year, we were in the Bandundu province, further north in the western part of what was then Zaire. And I noticed that the moms they would always soak the cassava tubers after peeling it. They would soak it for 3 days. Then they would dry those peeled cassava tubers in the sun for a day or two. They would pound it into flour, and then they would store it, and then later on mix it with boiling water to make the fufu, or the cassava dough. That's the basic staple, and then whatever sauce that they could make with it, along with stir fried greens from the cassava. That was what they that was what how they managed to feed the population, despite the difficulty oftentimes in growing other kinds of food-based crops. That's how they would, in the area where we're working in Kahemba, right near the Angolan border, about the only type of crop that can meet the nutritional needs of that population as it's moved back and crossed from Angola to the Congo, back to Angola, depending on the economic and political and activities going on, population moving back and forth. But if because of, for whatever reason, out of nutritional or economic hardship or near famine, whatever, if you don't soak that cassava for at least several days, dry it in the sun, then the cyanide won't have a chance to sufficiently evaporate. So when you pound it into flour and store it, then it could be high in cyanide. And if you don't have other sources of protein in your diet to help the liver detoxify this cassava, it can, over even a course of a few weeks, can cause permanent damage to the motor neuron system. And over time, we discovered and documented that it can cause damage to the central nervous system and to even brain and neural development, even in very young children after they're weaned from the cassava.
Yeah.
So there was a technique developed by Jean-Pierre Bania in partnership with Bradbury and an Australian team, whereby they discovered that if you take the cassava flour, whether it's been sufficiently processed or not, no matter what its toxicity was in cyanide, and if you make it into a paste and then dry it in the sun, ideally, but if it's raining and you have to dry it indoors, over the span of, say, 6 hours of drying this paste, that again, 95 to 97% of the cyanide will evaporate that way. So even if you haven't prepared the cassava flour, processed it sufficiently to remove the toxins, the cyanide, you can still make a paste of it later and dry that paste and then use it to prepare your cassava food, and it will still be safe. It's called a wetting method. We're partnered with Desiree Shalakatumbe. He's a professor, a neurologist, originally from the Congo, now at Oregon Health and Science University, as well as at the University of Kinshasa. And he received an NIH grant for 5 years to evaluate whether training the moms now in the wetting method within the villages in Kahemba, which had the highest incidence of Konzo disease on the planet. I mean, 1 in 20 moms, adults, children at some level affected by this cassava toxicity, in the form of Konzo, either overt or preclinical, that if we could go in and train the moms in using, in doing the wetting method to make their food safe, that we could effectively prevent Konzo disease in families that were formerly in villages where it was formerly highly prevalent. Now, the problem is it's very labor intensive, and these moms are already very busy gathering wood, washing, caring, cultivating their gardens, their fields. I mean, to add hours a day wetting through the wetting method, for virtually every time you want to make a cassava meal, is asking a lot. And so how to combine some other type of caregiver training? Well, that's where we use the MISC method from Uganda. We brought in our best MISC trainers from Uganda, who had been working with HIV affected families and mothers, and brought them actually to Kahemba, all the way to the Congo, our two lead trainers. And they trained a group of 10 community moms leaders who then became our MISC caregiver trainings. And we evaluated whether adding MISC training to the wedding method training that was already underway could actually enhance the adherence to the wedding method, as well as enrich the caregiving and developmental environment of these young children who are not just at risk of Konzo, but you can imagine to survive on toxic cassava, it takes the most extreme kind of conditions and poverty. And in fact, Konzo we've called a disease of extreme poverty, because if you have to subsist on toxic cassava, and if the soil is that poor and your agricultural options are that minimal, and the living conditions are that harsh in terms of water, clean water, and sufficient irrigation and fertile soil and so on, then it's a very, very difficult life, and so much that places the young children at risk. So there are a lot of reasons why caregiver training to enrich the lives of the children, not only to protect them from Konzo, but to protect them from many other kinds of risks and disease and other kinds of factors that could diminish their developmental potential. At any rate, we went into the communities and combining, using community leaders, working with the local health officials who, again, they're so far removed from the capital city, 2 days full drive, if you could even afford the fuel or get the diesel to get there. This community is pretty much on its own. And yet we were fortunate enough to partner with the director of Pronanu, promotion of good nutrition in the Ministry of Health, Jean-Pierre Bania, who's now passed away. But both his leverage and his ability to help us garner the resources needed at the government level, combined with community leaders and buy-ins for combining the wedding method now with caregiver training, that there was really the combination of these factors. And the moms were so encouraged, not just by being trained to do more work to make the food safe, but being trained in practical ways to help their children survive and develop and maybe go to school and succeed in life. That it was that hope and that dream for their children, combined with the practical need of protecting their children from a permanent debilitating neurological and neurocognitive disease in the form of toxicity in the cassava. Those two factors combined, it began to take root within the community, and women began training other women and promoting both wedding method and caregiving enrichment of their children to other neighboring families, other relatives, other clans and extended members within their community neighborhoods and households. So we begun to see a movement take root there that as moms and communities leaders saw the practical benefits, but didn't feel like they were just on their own. They had some measure of support at the government level as well, because of a really important partnership that we were able to mediate there. So that combination of ministry support with somebody who really believes and is really committed to the well-being of that distant community, as well as the moms, the families, the community leaders, the village chiefs and leaders, and their buy-in and cooperation, we begun to see something take hold there in response to Konzo disease, whereas before, all we could do was basically come in, tell them not to short soak their cassava and why it would hurt them, and then leave, and then hope that they would somehow find the means to persist with their wedding method in the face of all kinds of other hardships. But if you partner with them and you give them practical, meaningful, motivational, incentivizing ways to implement what's good for them and their families and their children, then they'll see the benefits, and it can begin to take root and take hold in and of itself and become something sustainable at the community level.
Yeah, it makes it easier for the work to keep going. So with what you're working on, where do you see your work going? In what direction in the future? Are there any other diseases that you've seen that you think it would be nice to work on in the future?
Well, I guess here's where I could go from preaching to meddling, but why not? I mean, you want this podcast to deal with the future for Africa. Really, will deal with food production, its agricultural resources, and how to harness that more and more for the benefit of its local communities. But the future, and I am speaking now more from what I've seen in the Congo, how Africa's wealth and natural resources can go back into its own communities. And I'll use, in terms of work we'd like to do, but which we haven't had a chance yet to implement, within the copper belt of the Congo, where much of the world's cadmium, cobalt, and in the east, oxal and other kinds of minerals that are highly prized and necessary for our cell phones, for our tablets, for our computers and our batteries, and so on. Those minerals are being harvested and used often at great cost to the local population. Tens of thousands who will work these open air mines, cobalt, let's say, where it permeates the soil, the air, the food, and they, tens of thousands of children, perhaps 100,000 or more adults who work these open air mines for pennies a day, barely enough to just feed themselves, to produce mineral wealth that runs our cell phones and our tablets and so on, for the batteries and everything that's needed for our technology. We know, based on some preliminary work that have been done by some of our partners, University in Lubumbashi, that these are having toxic effects on the neural development of children. How to encourage, though, governments in Africa not to hand over their raw resources to global economic powers on the rise, often at the expense and maybe even to the harm of their local population. That, to me, seems to be the most pressing concern today, and one that most of the world has ignored because most of the world wants its easy access to affordable technologies. They want their mobile phones and their tablets to run a long time on a single charge, and the minerals that make that possible and the technology that makes it possible depends still on parts of Africa that where the local population benefits very little. And if they could benefit from those kinds of resources, there wouldn't be such the desperate need to subsist on toxic cassava, which populations both in the south, east, and west, wherever you go in the Congo, must do, it seems. And even in the cities, when those toxic, poorly processed cassava flour is now sent to the city. So that's where I'd like to go with this kind of work, so that it wouldn't just be some obscure disease that I have to spend a half hour explaining because nobody's heard of Konzo, right?
Yeah.
To something real and meaningful, meaning the way in which toxic exposures in the environment through open air mines and the exploitation of mineral resources to run our technologies are being harvested by large rising economic powers and multinational corporations who basically collaborate with those governments that they sometimes put in power for that very purpose, so that they can gain that economic benefit. Ultimately, the human cost for that and the best way to intervene in the aftermath of that risk exposure, that's what we do. But that's only at a medical, individual, family, community level. Globally, nationally, regionally, that's where it's really happening and where it really needs to be addressed.
Yeah, I see what you mean. I'm wondering if the more effective method is not what you're doing right now, though. That problem, the way I look at it, is everyone that's involved in that is kind of profiting at some level. So it will be hard to kind of convince them to stop that. But at least helping the people is something that could help them like directly, like you said, at the family level, like help people individually. Because at that level, it's probably going to take time before things get a lot better the way it's moving right now. At least that's the way I see it. Because I think mostly it's not really so much that, I mean, the companies that come and then use the resources, yes, they're there, but it's mostly they're allowed to do that because the governments are behind them. So until the leaders are, I'd say, have enough integrity to not do that, it's going to be extremely hard to change that. At least that's the way I kind
Yeah.
of see that aspect, I guess.
Yeah, you're exactly right that so long as there's such a demand for coltran, for cadmium, for cobalt to drive our technology, and so long as there are companies, enterprises positioned in such a way, and this isn't just lately. I mean, these are rising economic powers that have been positioning themselves for this very thing over the long game, right? For decades now.
Yeah.
Whereas we were, at a time when we were more worried about combating Soviet influence in Africa, let's say, we as Americans, I guess I'm saying, and then later we began to really care about, but we cared about HIV mostly, it's to some extent malaria, a lot about tuberculosis. Why? Because those diseases could spread to our shores, and they did, right? And so we began to invest in health. But meanwhile, other countries were sending engineers, building infrastructure,
Yeah.
building capacity so that they could harvest the raw materials, and then at the same time, uh, establishing political partnerships and inroads, right? So that they could have the political wherewithal and needed to implement their economic um, plans and benefits. And so, how to redirect that now back to the benefit of the local population?
Mhm.
It would take leadership that's virtue and morally driven at some, and apart from, well, and again, here I can go from preaching to meddling, but unless you believe that there is a God and ultimately that we are held accountable as people, as families, as nations, as to the higher power, there's very little incentive to change, right? It's all for the here and now. It's all for the immediate economic benefit. But until such time as we see that we're really accountable to a much greater good and to a much higher power that ultimately does rule and reign and whose kingdom shall never perish, you're right. There's not much hope for effective change apart from that kind of level of renewal, repentance, restoration.
Mhm.
Yeah, yeah,
Yeah, and I guess the way I see it also is technically by helping people be in better health, and especially helping children be in better health, you're helping develop the next generation, and probably some of those who might get into power might actually be able to change that.
yeah. And that's the thing that we've tried to begun doing now with some of our more recent research, coming back more to the research angle. We've tried to gauge sort of the cost benefit in and just as a way of being able to present evidence to ministries, to government leaders that if you can invest in your children and you see the multi-generational benefits in this human capacity, that ultimately that's what will have the greatest impact. So selling out your natural resources and your raw materials at the expense of the local population, even to the harm of the local population, such as what's happening in the copper belt of the Shaba, in the Congo, for example, selling out and harming your local population and the food, the water, the air, everything, in order for short-term economic benefit to enrich, bank accounts of some in Switzerland or wherever, um, that if instead you could begin to redirect and that and understanding that someday we give an account for all that we do, for all that we become, for all the decisions we make, that we are held accountable ultimately. It isn't just for the here and now. That and then establishing that case with the fact that what your country will gain beyond the short term by investing in its human resource and the multi-generational benefits that will carry over generation after generation, and what that would mean in terms of compounded interest to your human capital. If you put away savings a little bit each day for today, 20, 30, 40 years down the road, suddenly you've built up a fortune and you didn't even see it growing. You didn't even realize. Well, it's the same thing with human capital. Investing in your children today, and as they invest in their children and their children and their children and beyond, the multi-generational capital that you'll gain by investing in the here and now in small ways in those first 1,000 days to redirect the developmental trajectory of your children at risk is far, far worth that 5 or 6% of your Ministry of Health budget that maybe donors will be kicking in half of it anyway. So yeah, I'm preaching, a bit here, but you get my point, and you capture the spirit of what it'll take. Yeah.
All right. Thanks a lot for taking the time to talk to us today. It was a very enriching discussion. I think first time we went into politics a little bit, actually.
How could that was the thing I discovered, when I was trained as a rat runner in the animal lab, it was all about control and keeping, scientific control and pure science in the lab. The moment you stepped out into the field to deal with malaria, and I found, okay, well, so why are these children dying from malaria? And then you look at, well, it's their exposure. They don't have windows. They sleep at night, and there's standing water all around the village in the rainy season, and there isn't adequate nutrition. They're immunosuppressed. I mean, why isn't there more resources? Why can't we get nets here? Should we use insecticides or not? How do we combat these infectious diseases and the risk for them during pregnancy? And then the more you start to pull at these strands in tackling one specific problem, the more you realize that it's a whole ecosystem that doesn't stop short of politics at the end, unfortunately, because at the end of the day, it's those kinds of jurisdictions that establish who gets to benefit ultimately and at whose expense. So you can do health, and you can try to stay out of any, stay in your lane, as we like to say, but sooner or later it broadens and it becomes about roads, schools, education, latrines, nutrition, market access to markets, and thereby having access to healthcare, thereby having access to education, thereby having access to the government, and what it allows you or doesn't allow you to do.
Yeah, as you're explaining that, there's actually one question that came back to mind. I was thinking back to the paper, and at some point there was, I think, it was that pregnant women are at a higher risk of contracting malaria than non-pregnant women of the same age. Do you have any idea why that is the case?
Well, it's often, we've really found that actually looked at that among pregnant women who are HIV positive, and even if they were on combination antiretrovirals, which they should be to prevent to sustain their own health and to prevent vertical transmission to their children perinatally, that they were especially at risk. Well, if you look at other kinds of comorbidities that come about from schistosomiasis, from other kinds of neurocysticercosis, other kinds of parasitic infections. In the Congo, initially, we looked at treating kids for malaria, and we found we didn't get much benefit. But if we combine that with treatment for intestinal parasites, and we combine those, treatment for malaria and treatment for intestinal parasites, vermifuge, with treatment for iron poor anemia, that there we would start to get a measurable benefit in their
Mhm.
working memory and cognition scores, you know. Well, it's the same, I think, for mothers. I think that moms, because they're struggling nutritionally, they may be struggling with other comorbidities, other infectious diseases, anemia, um, intestinal parasites, which we found if moms are positive for those, it can affect anemia in newborn infants and their early neural development. Because these moms don't live in a vacuum and it's not just one pathogen that they're dealing with. There's other kinds of bacterial and a host of other pathogens within their environment. And if their immunity system is compromised in some way, shape, or form, then they become more vulnerable to the more prevalent of those pathogens, which almost invariably is malaria. One other thing too is we found that moms who were less depressed and had more social support, let's say in the form of stable marriages, partnerships, good family support within the village, as opposed to being in isolation, having recently migrated to the city, let's say, urban flight, that moms who were less depressed, had more social support, tended to be more resistant to those kinds of gestational infections. And so, combined with emotional well-being, social support, quality of life, the things that we long for in the midst of, let's say, a pandemic lockdown, as we came to realize over the past couple of years, especially,
Yeah.
that the need for human community, and the loss of human community through relocation, through dispersement, through breakdowns in the family, in whatever culture, not just in the sub-Saharan village or the slum communities of the urban sprawl of Kinshasa, but here in the United States and Europe, wherever you go, the breakdown of community, social isolation, in and of itself becomes a pervasive immunosuppressant, making us more vulnerable, maybe not to malaria per se, but to whatever else that we're at risk for medically.
Thanks a lot for taking the time. I certainly learned a lot through this, and I'm pretty sure those who are watching this also are going to learn a lot through this discussion. If anyone wants to get in contact with you online through social media, what would be the best method?
You could go to our I'm director of our global neuropsychiatry research center at the Michigan State University. And if you go to Michigan State University, msu.edu, at their website, and you just search for global neuropsychiatry, our center will pop up right there as the first option, and just search for global neuropsychiatry, and go to that website within the MSU .edu, Michigan State University.edu homepage, and you'll learn all about not only my work but that of my outstanding colleagues, Dr. Amara Eziamama, Itziar Familiar Lopez, Horacio Escudero Lopez, Ala Sikorsky. I work with a great team, and we partner together on much of our sub-Saharan African maternal caregiving health-related work.
All right. Well, once again, thanks a lot for this, and hopefully we'll see you again very soon to talk a bit more about some of your future work.
Yeah, well, thank you, Robert. Thanks for taking the time and asking such great questions and being patient with me as I've continually gone from preaching to meddling. I hope that wasn't too much of a burden. Yeah.
That's good. It's always good to have new perspectives.
Bye-bye.